So this is about endocrine physiology from Ivmrcs. Start with the pituitary gland. The location of pituitary gland is sella turcica within the sphenoid bone. There is anterior pituitary and posterior pituitary. You have to remember this. It is from the Rathke's pouch, depression in the wall of pharynx, and this is coming from the floor of forebrain. Receives hormonal control from hypothalamus by hypothalamo-pituitary portal system. This is the portal system. Hypothalamus is above, pituitary is below. So whatever hormones are released from the hypothalamus, they are acting on the pituitary gland. This is to the portal system. Synthesized. While posterior pituitary hormones are already synthesized in hypothalamus, paraventricular nucleus secretes oxytocin, and supraoptic nucleus. This is supraoptic nucleus in the hypothalamus is secreting vasopressin or ADH. It is directly coming, so they are transported by hypothalamic pituitary tract and stored and secreted by posterior pituitary. So the hormones which are secreted by anterior pituitary, this is very important: growth hormone, prolactin, TSH, ACTH and LH. These are all hormones, important 5 hormones. GPTAL, growth hormone, prolactin, TSH, ACTH, luteinizing hormone. While growth hormone, prolactin, thyroid stimulating adrenocorticotropin, luteinizing hormone, these are TSH, ACTH, MSH, LH, FSH. Prolactin and growth hormone are secreted from anterior pituitary. Now posterior pituitary is secreting oxytocin, antidiuretic hormone. So whenever growth hormone are in excess than normal, so what will happen? Acromegaly. It will causing growth of the various body parts. Increases after union of epiphyses, then adult may have pituitary adenoma. So skull's size will increase, lip size will increase, separated teeth, vertebrae, there will be kyphosis, spade hands, enlarged feet, pituitary tumor, ME and type 1 syndrome. This is important gland, thyroid gland. It has got a follicle is containing colloid thyroglobulin. TSH is coming from above. This pituitary, anterior pituitary is secreting TSH. TRH is secreted from hypothalamus reaching pituitary gland, then pituitary glanding TSH. This is thyroid stimulating. It is stimulating thyroid follicles to form, release thyroglobulin. Colloid thyroglobulin is there, which goes release out thyroglobulin with iodine and tyrosine. Iodine and tyrosine combination forms thyroglobulin. 2 molecules of thyroglobulin forms diiodotyrosine. 1 diiodo and 1 monoiodo. These 2 diiodo will form T4. 1 diiodo, 1 monoiodo will form T3. So 90% majority is T4 and less is T3, which has got metabolic activity. T3 is periphery, it is acting on the cells. So what are the conditions that causes increase in hyperthyroidism? Primary means increase basic hormones T3, T4. Whenever there is increase this, they got opposite action on the pituitary gland. They asked to drop this secretion, so TSH will go down. This is primary. While in secondary, even if T3, T4 is increased, TSH is also increased. It is not TSH, the negative feedback mechanism has gone. It is not TSH. TSH is increasing, release of its own. T3, T4 release of own. The problem is somewhere else. Now in primary, it will be reverse effect. T3, T4 will be less, TSH will go on increasing. In secondary, both will go down. Now subclinical hypothyroidism. T3, T4 will be normal, but just TSH is increasing. Isolated T3, T3 only will be increased. Seek euthyroid, T3 may be normal or low, may be normal or low. The first hormone decrease in fever is the first hormone decrease in fever is TRH and TCH. Whenever a person gets fever, thyroid stimulating hormone goes down and person. So T3 is more active, so T4 is converted to T3 at the level of tissues. Signs of hypothyroidism. What are the conditions that may show you that the person is suffering hypothyroidism? A CNS, eyes, skin, cardiovascular, blood, GIT, limbs, genitalia. Right from top, start from the brain, eye, skin, heart, blood, GIT, limb, genitalia. From top to down, all the organs are affected by the deficiency of thyroid hormones. CNS, it will slow down apathy, sleep, to myxedema, coma. A person is sleepy, feeling simply, decreased recovery from anesthesia. Eyes, you will get a puffiness, loss of outer third of the eyebrow. There will be loss of outer third of the eyebrow. It is eyebrows are getting. Skin is cold intolerance. Hypothermia may be due to lead to coagulopathy and weight gain. Cardiovascular, there will be bradycardia. Heart will be slow, contractility go down, low voltage ECG, decreased contract, more dangerous intraoperative effect. Blood, there will be anemia, hypocholesteremia, hypercholesterol, cholesterol increases, constipation, GIT, perivertebral edema, muscle weakness, menstrual irregularities. So, how is this calcium homeostasis? Now, the another important hormone on a gland, that is parathyroid gland, it is secreting parathormone. And what is the mechanism of action of parathormone? It increases blood calcium level by so many mechanisms, acting on GIT, bone, kidney. Anything stimulus which shows that calcium level has gone down, parathormone will increase. That will stimulate GIT to absorb more calcium and parathyroid, increase calcium and parathormone absorption through vitamin D. So here the action is along with the vitamin D. Calcium as well as phosphate, both will be increased. pH is phosphate and CH calcium through vitamin D. On GIT is acting along with in synergy with the vitamin D. Hydroxylation forming 125 cholecalciferol. In bone, it causes reabsorption through indirectly osteoclast stimulate. Osteoblast is first acting. It is causing osteoclast to resorb the bone and release the calcium into the blood. In kidneys, it increases reabsorption from distal convoluted tubule and collecting tubule. Here, calcium is absorbed, but what happens? The phosphorus is not absorbed because calcium may join with the phosphorus to leading to formation of stones. So phosphorus is released from the proximal convoluted tubule and it is lost in the urine. So parathormone, when released, calcium is absorbed from the distal convoluted tubule and collecting, but the phosphorus is losing out. Then result is, what will be the result? Parathormone causes increased blood calcium level and decreased phosphorus level as phosphorus is lost. So high calcium, high parathormone, low phosphorus whenever there is primary parathyroidism. While calcitonin has got opposite action, it has got no action on GIT. It deposits the calcium into the bone, it decreases calcium, it decreases blood level in calcium as well as phosphorus loss. While vitamin D causes increased calcium and phosphorus absorption. Both of them, it deposits calcium into the bones, it increases absorption. So vitamin D increases calcium as well as phosphorus level. So what is the difference? Parathormone loses phosphorus, vitamin D uses both the things, increases. Parathormone is a polypeptide hormone. This is again a question. P is polypeptide. Parathormone half-life is only 10 minutes, so it may be used in intraoperative check. How vitamin D is formed? Cholesterol convert converted by ultraviolet rays to cholecalciferol in the skin. Then cholecalciferol in the liver goes to form 25 hydroxycholecalciferol. Then 25 hydroxycholecalciferol in the kidneys, it forms 125 hydroxycholecalciferol. So this is increased parathormone level. PTH is increased. So there are three things: parathormone, calcium, phosphate. So in primary, parathormone is increased means phosphorus has to low, calcium has to high. Parathormone is increased, calcium is increased, phosphorus less. Adenoma. But here, when there is patient is having chronic kidney patient or renal transplantation, there is hyperplasia of parathormone. So parathormone will be more, but calcium may be normal. It's not having, and kidney patient is there. So phosphorus is not filtered out. So phosphorus will also retain inside the body. While tertiary, there is hyperplasia, increased parathormone, increased calcium, and low phosphorus. Except in chronic kidney patient, there will be high calcium and high phosphorus. Parathormone will be high, this is low. Reverse, in chronic kidney patient, phosphorus will be retained inside and calcium will be low or normal. Coming to adrenal gland, it has got GFR. This is cortex, this is medulla. G is secreting ACS, aldosterone, cortisol, this sex hormones. Medulla is secreting catecholamines, adrenaline, non-adrenaline. So let us see, aldosterone is totally dependent on renin-angiotensin system. Aldosterone causes, it is a mineral corticoid. It causes sodium and potassium and water. So what happens whenever aldosterone is secreted? It is increase in Cons syndrome, hyperaldosteronism. Cons. Primary Cons syndrome has low renin, while secondary Cons syndrome has both the things are increased. Aldosterone. Cortisol is increasing. CO-dynan means it is retaining. Sodium is increased, so potassium opposite will be less. While cortisol is increased cortisol level, primary is pushing with low ACTH, while secondary is pushing with high ACTH. Sex hormones, adrenogenital syndrome, due to adrenal sex hormone is ACTH and all that. Catecholamines, pheochromocytoma, catecholamines attack due to tumor of the chromaffin cells, adrenal medulla. What is Addison's crisis? Sepsis or surgery, adrenal hemorrhage, Waterhouse Federation syndrome, steroid withdrawal. Suddenly there is low cortisol level, low aldosterone levels, that causes hypoglycemia, hypotension, pigmentation. ACT is given to differentiate between primary and secondary. Shots in actin test based on measurement of serum cortisol before and after injection. Prophylaxis by take cortisol at induction, and post operation if needed treatment by 100 mg of IV hydrocortisone. Pancreas, it has endocrine gland, islets of Langerhans. It has got beta cells, AG, alpha cell secrete glucagon, beta cell secrete insulin, delta cell secrete somatostatin. So it is pro-insulin. The rough endoplasmic reticulum pancreas, pro-insulin is to insulin by C peptides. Insulin is stored in the release in the response to calcium. And here is this. Insulin half-life is only 30 minutes. Metabolic effects of insulin, glucose uptake to the tissues and glycolysis, decreased blood glucose level, formation of glycogen. This is glycogen release in the muscles and adipose tissues, decreased blood level of potassium. This causes decreased potassium level. That's why in hyperkalemia, insulin is given, increased lipid and protein synthesis. There are two types of diabetes mellitus, type 1 and type 2. Type 1, 10% of the patient. Type 2 are more common. Abnormal insulin resistance at the site of action. Here, pancreas is normal, but site of action is abnormal. So you have to give, instead of giving insulin, body insulin containing more, but you have to give oral hypoglycemic drugs. Here there is deficiency of damage to pancreas, less insulin, so insulin has to be given. How to diagnose diabetes mellitus? Fasting post meal. Fasting is normal glycemia is 6.1 to 7.8, and glucose tolerance test 6 to 7 is GTD, impaired glucose tolerance, 7.8 to 11. Diabetes mellitus, if it is more than 7, this, and more than 11 postprandial, then it is diabetes mellitus. This is again question, more than 7, more than 11 has to be there. On GTT it has to be up to 7. Normal level is 6 to, this is normal. Now impaired glucose or pre-diabetics, impaired glucose tolerance. So renal papillary necrosis, in which cases the person suffers sequelae of ischemia in the renal papillae. Renal papillae is apex of the medullary and presents a confluent collecting from each of the nephron. This is soda. Sickle cell, obstructive diabetes questions are there. Diabetes mellitus, there is renal papillary necrosis. Any of the sickle cell, there is renal papillary necrosis. Flank pain is there, fever is there, hematuria or slough in the urine. Slough in urine. Anti-insulin hormones which increase glucose level. Glucagon, growth hormone, thyroid, cortisol, all these increases blood glucose level. Cortisol causes gluconeogenesis to increase blood glucose level. Catecholamines also causes gluconeogenesis to increase blood glucose level. What are the stress response to the hormones? The thing question which is asked is which hormones are decreased. Basically insulin is decreased. Basically you want blood sugar level to be raised before stress, so that's why insulin is automatically coming down to maintain the high blood sugar level. Testosterone and estrogens are getting down. These are the hormones. No change FSH, LH and TSH. Rest all the growth hormone, prolactin, ADH, cortisol, aldosterone, glucagon, all these are increasing. Paraneoplastic syndromes. What does it mean by paraneoplastic syndrome? This is neoplastic. There is some malignancy somewhere. It is causing hormonal effect. Like Cushing's syndrome. Whenever there is small cell cancer, adrenocorticotrophic hormones are secreted, and that leads to increased cortisol level. Small cell cancer, they are stimulating antidiuretic posterior pituitary. When they stimulate anterior pituitary, they are causing stimulation to the hypothalamus to release the hypothalamus releasing hormones. They are secreting, ACTH is secreting, it is acting on the adrenal cortex leading to increased cortisol. It is acting on the adrenal ADH is secrete hyponatremia causing SIDH. Parathermal related peptide. This is parathermal related peptide secreted causing hypercalcemia. Small cell cancer, squamous cell cancers, gastric cancers causes acanthosis nigricans because of melatonin. Melanin is secreted. Polycythemia. This increases the cell count. There is thrombocytosis, increased cell count in renal cell carcinoma.